Welcome in. It's great to have you with us for another custom deep dive. Today we're taking a look at a world that completely defies expectations. Because if you think about it, most of us have a very fixed image in our heads of what orthodontics is, right?
Oh, absolutely. I mean, you picture middle school hallways, um, awkward yearbook photos, the
Yeah.
the inevitable neon rubber bands.
Right, exactly. But we've got a stack of sources today that completely dismantles that stereotype. We're pulling from some incredibly dense foundational texts like contemporary orthodontics, alongside these really deep dive biological research papers and comprehensive clinical handbooks.
And the literature we're looking at today is fascinating because it forces you to look at a seemingly mundane dental procedure through the lens of psychology, advanced cellular biology, and even pharmacology.
Yeah, our mission today is to figure out exactly what happens when an adult decides to completely change their smile, because the clinical data on this demographic shift is something you really can't ignore.
No, you can't. The numbers in these texts show a massive pivot. We're no longer just talking about teenagers who are passively sitting in a chair because their parents told them they had to.
The data shows that adult orthodontics is booming. Currently, adults make up anywhere from 20 to 28% of all orthodontic patients.
And it's predominantly, I think the number was about 71% of those adult patients are female.
Right. But treating an adult isn't just a matter of gluing the same metal brackets onto older teeth. These sources reveal how an adult's biology, their deeply ingrained psychology, and even the medications they take every single morning completely alter the way teeth actually move through bone.
It's a completely different landscape.
It really is. Okay, let's unpack this. I want to start with what the textbooks refer to as the psychosocial battlefield. Why this sudden massive influx of adults into these clinics?
It really comes down to a fundamental shift in motivation. When you treat an adolescent, their motivation is almost entirely passive.
It's just a rite of passage for them.
Well, exactly. But when an adult walks into a clinic, their motivation is incredibly active. It's usually tied to high-stakes life factors, aesthetics, career advancement, major life transitions, and just overall quality of life.
And the clinical handbooks spend an unexpected amount of time analyzing the sheer societal weight that facial appearance carries. That historical context in the textbooks was actually a bit jarring to read.
Oh, the historical perspectives are intense.
They really are. They go through how different jaw structures and malocclusions have been treated throughout history and culture. There's a section detailing how a class 3 malocclusion, where the lower jaw protrudes significantly past the upper jaw, has historically been caricatured in literature and art as the face of a witch.
Yeah, that imagery is so deeply ingrained in our cultural subconscious.
And on the flip side, severe protrusion of the upper incisors has been constantly, and obviously unfairly, stereotyped as an indicator of someone who isn't highly intelligent.
Right, the none too bright stereotype.
Yes. Exactly. And when you read that, you suddenly realize the subconscious biases adult patients are fighting against. For you listening, the psychological stakes here are massive.
They are, and those stakes heavily influence the clinical approach. Because the societal pressure is so intense, the literature emphasizes that clinicians have to carefully categorize an adult patient's motivation before they even consider treatment.
They break it down into internal versus external motivation, right?
Yes, internal motivation is the ideal scenario. The patient recognizes a physical reality about their smile, they want to change it for their own self-esteem, and they take full ownership of the process and the discomfort that comes with it.
And the dangerous side of that coin is the external motivation, doing it because of outside pressures.
It's the ultimate red flag clinicians are trained to look out for. External motivation is when a patient believes that fixing their teeth is a magic bullet for a complex external problem.
Like trying to save a failing marriage.
Exactly. Or appease a highly critical spouse, or land a promotion at a job where they feel overlooked. The handbooks are explicit about this. If an adult expects orthodontics to fix their social or financial reality, the treatment is clinically doomed.
Because when the braces inevitably come off,
And the marriage is still failing or the promotion still doesn't happen, all of that intense psychological frustration is redirected as resentment toward the orthodontist and the treatment itself.
which opens the door to an even darker psychological element discussed in the clinical handbooks. We're talking about body dysmorphic disorder, or BDD. I knew BDD was a factor in plastic surgery, but the prevalence in orthodontics absolutely floored me. How common is this in the adult ortho population?
The statistics from the psychiatric screening data are genuinely alarming. In the general population, BDD is relatively rare, affecting somewhere between 0.7 and 2.5% of people.
Right.
But when researchers screen the adult orthodontic population, that number skyrockets to between 5 and 13%. And it gets even more extreme when you look at patients seeking orthognathic surgery, which involves physically cutting and repositioning the jawbones. Up to 17% of those patients meet the diagnostic criteria for body dysmorphic disorder.
Nearly 1 in 5 patients seeking jaw surgery. For you listening, the sources make a critical distinction here. BDD is not vanity. It's not just caring about how you look.
No, not at all. It's classified as a severe condition on the obsessive-compulsive spectrum.
Right. A person with BDD fixates on a microscopic or sometimes entirely imagined physical defect. They might spend hours agonizing over a half-millimeter facial asymmetry that literally no one else can perceive.
And that profound disconnect from reality is where the clinical danger lies. A BDD patient's psychological distress is completely disproportionate to their actual anatomical presentation.
And the textbooks are very clear on how to handle this, aren't they?
The psychiatric and orthodontic texts are completely aligned on this. Providing a BDD patient with physical treatment, whether it's clear aligners, traditional braces, or jaw surgery, will not alleviate their psychological distress.
It actually makes it worse.
In fact, altering their appearance almost always exacerbates the disorder. The patient will either hyperfixate on the new alignment, claiming it's still slightly off, or their obsession will simply migrate to a new imagined defect elsewhere on their face.
It paints a picture of the orthodontist not just as a dental specialist, but as someone who has to navigate a minefield of mental health issues.
They absolutely do.
The textbooks outline these incredibly specific red flags clinicians are supposed to look for. Things like a patient constantly checking their reflection in the metallic surfaces of the dental equipment.
Or excessive grooming in the waiting room.
Yeah, or bringing in photos of themselves that have been heavily manipulated with filters to show the doctor exactly what they expect to look like.
This raises an important question. How did a specialist trained in biomechanics and bone remodeling end up having to act as a frontline psychiatric screener?
Right, it's wild.
Before they ever take an impression or bond a single bracket, they are required to evaluate ego strength and psychological stability. If a clinician suspects BDD based on those behavioral red flags, the established protocol isn't to proceed cautiously with braces.
This hard stop.
It is.
Yeah.
The protocol is to refuse physical treatment and gently redirect the patient towards psychiatric counseling or cognitive behavioral therapy.
It's a massive, often unrecognized responsibility. But the sources don't just dwell on the psychological differences between adults and teens. They dive deep into the fact that the adult skull and the biology of the adult mouth are fundamentally structurally different.
Yes.
We're not just dealing with mature minds, we're dealing with mature, rigid bone.
The shift from the psychological to the physiological is where the mechanics of this field get incredibly complex. The baseline reality that governs every single adult treatment plan is that an adult patient has absolutely zero growth potential.
I was trying to wrap my head around what that actually means in the chair. In a teenager, the jaw is still actively forming. You can use relatively simple appliances to physically widen the jawbone because the mid-palatal sutures, the joints running down the roof of the mouth, haven't fused yet.
Exactly. You're literally guiding growth.
But in an adult, those sutures are locked solid, right?
They're completely fused and ossified. You cannot expand an adult skeletal base with a standard palate expander.
What happens if you try?
You would just tip the teeth sideways out of the bone. It's a mechanical impossibility.
Ouch.
But the limitations go much deeper than just fused sutures. The cellular environment itself is entirely different. Tooth movement is a biological process masquerading as a mechanical one.
Okay, break that down for us.
When force is applied to a tooth, it triggers a localized inflammatory response. That inflammation summons specific cells that break down the bone and firm the moving tooth, and different cells that build new bone behind it.
And in a growing adolescent, that cellular environment is highly vascular. There is a rich, robust blood supply, meaning those cellular armies mobilize very quickly.
Right, and adults just don't have that same vascularity. The basic science papers detail how blood supply to these tissues significantly decreases with age.
Which means the cellular activation required to remodel the bone takes a frustratingly long time to initiate. Just how fast are we actually moving bone here?
It's microscopically slow. Even under absolute optimal conditions with perfectly calibrated continuous force, a tooth is generally only moving about zero point 0.8 to 1.2 millimeters per month.
A millimeter a month. That is agonizing.
And the sources point out that achieving even that tiny amount of movement in an adult is biomechanically taxing.
Yeah.
Because the cell turnover is diminished, if an orthodontist tries to rush the process and applies too much force, the sluggish biology can't adapt.
And that leads to one of the most severe complications discussed in the literature, root resorption.
Yes, it's a massive risk factor.
If the mechanical force overwhelms the biological capacity of the adult bone to remodel, the cells get confused, for lack of a better term.
That's a good way to put it. Instead of eating away the surrounding bone to let the tooth pass, the cells actually start eating away at the root of the tooth itself.
It's a devastating complication where the roots become blunted and shortened, compromising the lifelong stability of the tooth.
Which is exactly why you can't just crank the wires tighter to make it go faster in an adult.
But what's amazing is how the research papers see the field evolving to combat this sluggish biology. They dedicate a lot of time to the future of precision or personalized medicine.
Oh, this is where the science gets really exciting.
Instead of an orthodontist looking at an x-ray and making an educated guess about how much force an adult jaw can handle, they're looking at molecular science.
The horizon for this is fascinating. The research is moving heavily into biomarker analysis. Clinicians will soon be utilizing genetic markers found in a patient's saliva.
Or specifically in the gingival crevicular fluid, right?
Yeah. Yes, which is the fluid naturally present in the microscopic crevices between the gums and the teeth. By analyzing that fluid, they can look at your specific DNA and your individual protein expression.
And what did that tell them?
They'll be able to predict, with mathematical certainty, your unique rate of bone remodeling and your specific genetic susceptibility to root resorption.
Just imagine that consultation in a few years for you listening. You sit down and instead of just taking a mold, they take a genetic swab. Based on your specific DNA profile, they 3D print a custom appliance calibrated to deliver the exact micronewtons of force your specific bone density can handle.
The texts even speculate about using specialized biologic or pharmacologic agents, maybe a gel applied to the gums to artificially speed up your localized cellular response.
If we connect this to the bigger picture, this means the end of one-size-fits-all orthodontics.
Absolutely. We're looking at the definitive end of that era. For over a century, the field has been dominated by mechanical physics. Wires, brackets, springs acting on bone. Precision medicine elevates it to a true biological therapy.
You aren't just treating a malocclusion based on a plaster model. You are actively managing a patient's genetic code.
It's a complete paradigm shift.
Here's where it gets really interesting, because even without those futuristic genetic tests, an adult's current daily life is actively chemically altering how their teeth move.
This is a biological intersection most people never consider.
The sources dive into this incredible chemical collision between an adult's stress levels, the medications in their medicine cabinet, and their bone remodeling. Let's start with the stress factor.
Right. Well, we just talked about the cells responsible for moving teeth, the osteoclasts that break down bone, and the odontoclasts. What the immunological research reveals is that these specific bone remodeling cells are actually derived from the body's immune system.
They are part of the macrophage lineage.
Exactly. They are immune cells, meaning anything that modulates or stresses your immune system is going to directly impact your orthodontic treatment.
And in the adult population, one of the most potent modulators of the immune system is chronic psychological stress.
It is. When an adult is under severe stress, it hyperactivates the hypothalamic pituitary adrenal axis, the HPA axis. This triggers a cascade of stress hormones like cortisol.
And what does that cortisol do to the teeth?
The literature clearly demonstrates that this stress-induced HPA axis activation directly disrupts the function and recruitment of those immune-derived bone cells. Studies show that adult patients reporting high levels of psychological distress have a remarkably higher incidence of severe root resorption and delayed tooth movement.
The mind-body connection here is intense. And the sources provide a wild clinical case study by a researcher named Davidovich to illustrate just how extreme it can get. He documented the case of an adolescent patient who developed a condition called alopecia totalis during their orthodontic treatment.
It's a highly cited and very sobering case report. Alopecia totalis is an autoimmune condition resulting in the complete and rapid loss of all scalp hair.
And they linked it to the braces.
Well, when the medical team investigated this sudden onset, they ruled out standard underlying systemic diseases. Their conclusion highlighted a perfect storm of stress.
kind of stress?
The patient was experiencing severe, persistent psychological distress in their personal life. The medical review proposed that this profound internal stress was biologically amplified by the constant low-level physical and mechanical stress of the orthodontic mechanotherapy.
The actual pressure of the wires.
Yes. The combination sent the immune system into an overdrive state, triggering the severe autoimmune response that caused the alopecia.
That is just mind-blowing. The sheer mechanical stress of the braces acting as a force multiplier for psychological stress. But it's not just internal stress hormones throwing a wrench into the biology, it's the daily medications.
The pharmacology section of these texts is a must-read for any clinician treating adults.
The texts outline how common adult prescriptions chemically interfere with the basic mechanism of braces.
The mechanism of tooth movement relies entirely on a localized, controlled inflammatory response. When you pull a tooth, the tissue stretches, creating inflammation, which produces localized hormones called prostaglandins.
Prostaglandins are the chemical messengers that tell the bone to start remodeling.
Exactly. They are the signal. And the problem is, millions of adults are taking medications designed specifically to stop inflammation.
The sources specifically call out SNRIs, which are heavily prescribed for major depressive disorder.
Yes, and tricyclic antidepressants, like amitriptyline, which are often used off-label for chronic pain management.
So what happens when a patient on these meds gets braces?
The systemic administration of these drugs acts as a massive roadblock. Amitriptyline and many SNRIs have potent anti-inflammatory and antiprostaglandin effects.
So they block the exact signal the braces are trying to send?
Precisely. If you have a patient taking these daily, the medication is actively suppressing the exact prostaglandin cascade the orthodontist is trying to induce with the wire.
The biological engine that allows the tooth to move through the bone is essentially being starved of its fuel.
The bone refuses to soften, the teeth become incredibly sluggish, and a treatment plan that was supposed to take 18 months drags on indefinitely.
It's fascinating to think about an orthodontist scratching their head, wondering why a tooth isn't tracking, and the culprit is actually an antidepressant the patient didn't think was relevant to mention to their dentist.
It happens all the time.
But we can't just look at the systemic chemistry. We have to look at the local physical environment. Let's talk about the foundation of the adult mouth, the periodontal terrain.
The periodontal reality is often the biggest hurdle in adult orthodontics. When you treat a 12-year-old, their gingival tissues and underlying alveolar bone are almost always pristine.
But as we age, the cumulative wear and tear and the prevalence of periodontal disease increase dramatically.
They do.
The analogy that came to mind while reading these clinical handbooks is that putting braces on an adult is like trying to renovate a century-old house.
Oh, I like that analogy.
Right. You might have grand plans to install beautiful, heavy new bay windows representing the perfectly straight teeth. But if you ignore the fact that the wooden foundation of the house is rotting and termited, the moment you start knocking down walls to put those windows in, the entire structure is going to collapse.
It's an incredibly apt analogy because the destruction is just as catastrophic if the rules aren't followed. The texts establish a rigid, non-negotiable golden rule for adult treatment.
What is it?
Any active periodontal disease must be entirely arrested before a single orthodontic force is applied. They don't leave this up to clinical interpretation. They give exact metrics.
So they can measure it.
Exactly. A patient's periodontal pockets, the spaces between the gum and the tooth, must measure under 5 millimeters, and the bleeding on probing index must be below 15%.
And if it's not, what happens if an orthodontist ignores that and puts braces on anyway?
If an orthodontist applies mechanical force to a tooth while the surrounding gums are actively inflamed and infected, it acts as a catalyst, causing a rapid, aggressive, and entirely irreversible breakdown of the supporting alveolar bone.
The bone just melts away.
The teeth will literally become loose and fall out.
And even if the disease is controlled, the history of bone loss changes the physics of how the tooth moves. The sources spend a lot of time on a concept called the center of resistance. Can you break down why missing bone makes tooth movement so perilous?
It's pure biomechanics. Every tooth has a center of resistance, which is the balance point of the root embedded in the bone. Imagine a heavy wooden fence post buried deep in the ground.
Okay, I'm picturing it.
If the dirt is packed high and tight all the way to the surface, the center of resistance is high. If you push on the top of the post, the whole post stays relatively stable and moves uniformly through the dirt.
But if years of erosion wash away half the dirt around the post,
That center of resistance moves drastically lower. closer to the very bottom tip of the post.
So if you push on the top of the post now, it doesn't move uniformly. It just acts like a lever and tips right over.
Precisely. In an adult patient who has lost vertical bone height due to historical gum disease, the center of resistance of their teeth has migrated apically, down toward the root tip.
So standard braces won't work the same way.
If an orthodontist applies a standard traditional force to the crown of that tooth, it won't translate bodily through the jaw. It will tip dangerously, potentially pushing the root right out of the remaining bone.
To counteract this altered physics, the clinician has to engineer highly customized biomechanics using ultralight forces and specialized wire bends to ensure the tooth remains upright as it moves.
It requires an incredibly light touch.
And on top of the bone loss, you have the restorative nightmare. The texts refer to this as adjunctive orthodontics.
Right, the reality of adult teeth.
Adults rarely have a mouthful of untouched virgin enamel. They have a history of dental work. Amalgam fillings, gold crowns, porcelain veneers, zirconia bridges. Gluing a metal bracket to that landscape sounds like it requires a degree in industrial chemistry.
It requires a profound mastery of dental materials because standard orthodontic resin only adheres to natural enamel. The clinical guidelines outline meticulous, heavily regimented protocols for bonding to artificial surfaces.
Like if you have a gold crown.
If a clinician needs to bond a bracket to a gold crown or an old amalgam filling, they can't just use standard acid etch. They have to isolate the tooth and sandblast the metal surface with 50-micron aluminum oxide powder.
Sandblasting in the mouth.
Yes, to create a micromechanical texture for the glue to grab onto.
And the porcelain protocol sounded even more intense.
It is significantly more hazardous. To bond to a porcelain veneer or crown, the surface must be treated with 9.6% hydrofluoric acid.
Hydrofluoric acid is serious stuff.
It is highly toxic and can cause severe tissue necrosis if it touches the gums. It requires impeccable moisture control and isolation. The logistical overhead of just setting up an adult mouth for braces is staggering compared to a teenager.
Which really highlights how interconnected the oral cavity is with the rest of the patient's medical profile. You can't separate the teeth from the gums, and you certainly can't separate the gums from the body's systemic health.
No, everything is linked.
The sources dedicate a massive section to adult medical mysteries, detailing how specific chronic conditions force a complete rewrite of the standard orthodontic playbook. Let's start with diabetes mellitus.
Diabetes is a prime example of a systemic condition that profoundly dictates local orthodontic treatment. We know that diabetes fundamentally compromises the microvascular system and impairs the body's ability to heal.
The textbooks provide stark warnings here.
They do. If a diabetic patient's blood glucose is poorly controlled, coupling that vascular compromise with the inflammatory mechanical force of braces will cause the periodontal support apparatus to rapidly deteriorate.
Because the bone needs blood to heal.
Exactly. The alveolar bone simply cannot sustain the metabolic demand of remodeling without adequate, healthy blood flow, and it will begin to melt away.
So strict glycemic control is paramount. But the handbooks also dictate changes to the actual logistics of the appointment. It's not just about what you do in the chair, it's about when they are in the chair.
The timing is critical.
They explicitly state that appointments for diabetic patients must be scheduled in the morning, and the clinician must verify that the patient has eaten a normal meal and taken their medication prior to sitting down.
Right, to avoid inducing a hypoglycemic crisis mid-adjustment. The protocols are incredibly specific.
Another highly complex medical scenario covered in the literature involves patients who have undergone solid organ transplants.
With advancements in transplant medicine, we are seeing a much larger adult population with heart, liver, or renal transplants seeking elective dental care.
The protocol here is absolute. Orthodontic treatment must be strictly delayed for a minimum of 6 months post-transplant.
And that 6-month window is tied directly to the pharmacology of the transplant.
The massive doses of immunosuppressants.
Correct. During that initial post-transplant period, patients are on peak doses of immunosuppressive therapy to prevent organ rejection. These drugs cause profound bone marrow suppression in a condition called oral mucositis.
What does that do to the mouth?
The mucosal lining of the mouth becomes incredibly fragile, inflamed, and prone to severe ulceration. Introducing sharp metal brackets, wires, and constant mechanical irritation into a mouth that is essentially stripped of its immune defense and tissue integrity would invite massive systemic infection.
It makes complete sense when you lay out the biology, but out of all the medical conditions discussed, the section on eating disorders, specifically bulimia nervosa, really stood out as a critical intersection of dentistry and mental health.
Eating disorders present a uniquely destructive challenge to the oral environment. The defining behavior of bulimia recurrent, self-induced vomiting constantly bathes the oral cavity in highly acidic gastric contents.
And stomach acid is brutal on teeth.
It dramatically lowers the pH of the mouth, leading to aggressive, severe chemical erosion of the enamel. Clinically, this erosion is most pronounced on the palatal surfaces, the back sides of the upper anterior teeth, where the acid hits most directly.
And the texts offer a really specific, almost counterintuitive warning here regarding treatment modalities. Adult patients typically gravitate toward clear aligners because they are practically invisible and highly aesthetic.
They are the most requested option.
But the guidelines strictly contraindicate clear aligners for patients with an active eating disorder. Why is that specific appliance so dangerous?
Because of the physical design of the appliance itself. A clear liner is a tightly adapted plastic shell that covers the entire tooth.
Right.
If a bulimic patient wears their aligners during a purging episode or puts them back in immediately afterward without neutralizing the oral environment, that tightly fitting plastic tray acts as a sealed reservoir
It traps the highly acidic gastric fluid against the enamel.
and holds it there, preventing the mouth's natural saliva from washing it away or buffering the pH. It exponentially accelerates the destruction of the tooth structure.
What's fascinating here is how the orthodontist is positioned to be the medical detective in these scenarios. A patient might successfully hide an eating disorder from their primary care physician, their friends, and their family.
But they can't hide the palatal enamel erosion, the vascular changes in the gingiva, or the altered rate of bone remodeling from an observant orthodontist.
The sources emphasize that the dental specialist is frequently the very first healthcare provider to spot the physical manifestations of these hidden systemic and psychological conditions.
It underscores the necessity of comprehensive medical screening. But even when a patient is systemically healthy, cytologically sound, and free of periodontal disease, there is a physical threshold to what wires and brackets can actually achieve.
Sometimes braces just aren't enough.
When the skeletal discrepancy between the upper and lower jaw is so massive that the teeth simply cannot be tipped or moved enough to mask it, the clinician has to look at surgical intervention.
And that brings us to the final major clinical topic in the sources, the extreme makeover, orthognathic surgery. When camouflage orthodontics, which is just tilting the teeth to hide the underlying skeletal mismatch, isn't physically possible, we are talking about major invasive procedures.
Yes, very invasive.
The texts detail surgeries like the bilateral sagittal split osteotomy or BSSO.
Where they literally split the lower jaw down the sides to slide it forward or backward.
And for the upper jaw, they utilize Lefort eye impactions, detaching the entire maxilla from the skull to reposition it.
These are profound structural alterations. But what makes the orthodontic management of these surgical cases so fascinating is the preparatory phase.
It involves a concept known as decompensation, which is highly counterintuitive to the patient.
It is entirely backward to what they expect. If an adult has lived with a severe skeletal underbite for 30 years, their body hasn't just ignored it. Nature attempts to mask the skeletal error with dental compensation.
How does the body do that?
The lower incisors will naturally tip heavily backward, and the upper incisors will flare sharply forward, stretching toward each other to try and establish some kind of functional bite despite the jaws being completely misaligned.
So nature is already trying to perform camouflage orthodontics. But to get ready for surgery, the orthodontist has to actively undo all of that natural compensation.
They have to completely reverse it. The orthodontist uses traditional braces to move the teeth out of their compensated positions and place them back over their true anatomical skeletal base.
Visually and functionally, this means the orthodontist is making the patient's bite objectively worse for 12 to 18 months leading up to the surgery.
Much worse.
Yeah.
If they started with an underbite, the decompensation process will make that underbite significantly more severe and pronounced. The teeth won't touch, chewing becomes difficult, and the facial aesthetics are temporarily worsened.
The psychological trust required to endure that is immense. You are paying a professional to make you look worse for over a year with the promise that a surgeon will eventually fix it.
It's a huge commitment.
But the texts also highlight a paradigm shift in this protocol that is gaining a lot of traction. The surgery-first orthognathic approach, or SFOA.
This is a game changer.
The idea here is to skip the miserable year of decompensation. They just put the braces on, send the patient straight to the operating room, break the jaw, move it to the ideal skeletal position, and then figure out the tooth alignment afterward.
The clinical rationale behind the surgery-first approach is deeply rooted in bone metabolism. It capitalizes on a biological cascade known as the regional acceleratory phenomenon.
What happens during that phenomenon?
When the maxillofacial surgeon cuts and repositions the jawbone, it causes massive localized trauma to the tissue and bone. The body's evolutionary response to severe bone trauma is to flood the surgical site with inflammatory mediators, osteoclasts, and osteoblasts.
To heal the break.
Exactly. It drastically ramps up the local metabolic rate to heal the fracture.
It's like a biological state of emergency.
Yes. And the orthodontist harnesses this temporary, supercharged metabolic state. Because the adult's typically sluggish bone metabolism has been artificially accelerated by the trauma of the surgery, the teeth can be moved at an incredibly rapid pace in 3 to 4 months immediately following the operation.
They just fly through the bone.
The teeth essentially fly through the softened, highly active bone, dramatically reducing the overall treatment time.
Using the body's own trauma response as a speed boost for the braces, it's brilliant. But the sources do not gloss over the grueling reality of the recovery. We already touched on body dysmorphic disorder, but even for a psychologically robust, highly motivated patient, the post-operative period is a gauntlet.
It is a severe physical and mental test.
The textbooks specifically warn clinicians to monitor for severe mood instability and depressive episodes occurring predictably around 3 to 6 weeks post-surgery.
That depressive window is largely driven by physiological exhaustion and pharmacology. To manage the immense restrictive swelling associated with moving facial bones, patients are administered high intraoperative and post-operative doses of corticosteroids.
And what goes up must come down.
The subsequent withdrawal from those steroids over the following weeks, combined with strict liquid dietary restrictions, significant weight loss, disrupted sleep, and the psychological shock of looking in the mirror and seeing a massively swollen, unfamiliar face creates a deep emotional vulnerability.
The clinical team must heavily prep the patient and their support system for this inevitable physiological crash.
They have to know it's coming.
And once they are through the surgery, or even for adults just doing traditional braces, there is one final mechanical hurdle driven almost entirely by adult vanity. The texts talk about anchorage.
Anchorage is a fundamental physics problem.
Basic physics says that to pull a tooth in one direction, you need an anchor to pull against. If you pull on a front tooth using a back tooth as an anchor, the back tooth is going to move forward a little bit too.
For every action, an equal and opposite reaction.
In kids, if you need absolute anchorage, you might use headgear, a heavy appliance that straps around the neck or the back of the head. But the sources note that adults flatly refuse to wear traditional headgear.
They aren't going to wear a neck strap to their corporate board meeting.
The aesthetic refusal of extraoral appliances forced the industry to innovate, leading to the massive rise of TADs or temporary anchorage devices.
If the orthodontist cannot use the back of the patient's skull for leverage, they have to create an immovable anchor directly inside the mouth.
And TADs are exactly what they sound like. Actual miniature titanium screws that the orthodontist drills directly through the gingival tissue and into the solid alveolar jawbone.
Just burying a titanium screw right into the jaw to use as a grappling hook.
It sounds medieval.
But it provides absolute skeletal anchorage. Once the titanium screw is integrated into the bone, the orthodontist can attach springs or elastics from the screw directly to the teeth they want to move.
Because the screw is embedded in the solid bone, it does not move,
allowing the clinician to drag the teeth backward without relying on patient compliance or ruining the aesthetic presentation with bulky external gear.
So what does this all mean? If you or an adult you know is standing in front of the mirror, pulling back their lip, and thinking about finally fixing that crowded incisor or that misaligned bite, the reality is that you are stepping into a process infinitely more complex than a middle school rite of passage.
It's a profound, multidisciplinary journey. We've traced the entire landscape today. We've looked at the intense psychological hurdles, moving from highly motivated internal desires to the clinical dangers of external pressures and body dysmorphic disorder.
We've explored the stubborn biological reality of fused adult sutures and sluggish cellular turnover, and how something as routine as a morning antidepressant can chemically stall the entire process.
We've examined the absolute necessity of a pristine periodontal foundation, the logistical nightmare of bonding to porcelain, and the extreme life-altering lengths of surgical decompensation and orthognathic correction.
It fundamentally reshapes how you view adult orthodontics. It's not cosmetic dentistry, It is a rigorous example of holistic medicine.
It really is.
It is a highly choreographed process where an individual's vanity, their hidden mental health struggles, their unique genetic code, their immune system responses, and their daily pharmacological habits all physically converge in the bone of their jaw.
It is an amazing, chaotic synthesis of psychology, cellular biology, and mechanical physics. It demands a clinician who is as adept at reading a psychological profile and a medical history as they are at bending a titanium wire.
And as precision medicine continues to integrate molecular science into the clinic, that holistic connection is only going to become more explicit.
Tailoring the biomechanics to the unique DNA of every single patient who sits in the chair.
Which brings us to a final, slightly wild thought to leave you with today. We've discussed how the research is pointing toward a future where we test saliva and gingival fluid to predict exactly how your specific bone will remodel under the mechanical stress of wires and titanium screws.
The diagnostic potential is incredible.
But if we are getting to the point where we can map the exact genetic markers and protein expressions that trigger osteoclast to dissolve bone and osteoblast to rebuild it, how far away are we from a future where we abandon the mechanical hardware entirely?
That is the ultimate question.
Could the next true evolution of orthodontics simply be a highly targeted, localized genetic therapy? Imagine a custom-formulated mouthwash or a microinjection into the gums that chemically instructs your own adult jawbone to spontaneously soften, reshape, and permanently realign your teeth on its own, guided entirely by your DNA, without a single bracket ever being glued to your enamel. Something to chew on. Thanks for taking this deep dive with us.